Ben Freedman returns, this time with Dr. Hein Heidbuchel, professor of cardiology at the University of Louvain in Belgium. They cover NOACs, update on the European Heart Rhythm Association practice guideline.
We used to call them novel anticoagulants. Do we call them something else? We keep the NOAC in?
Yeah, we kept the term NOAC, but it stands now for non-VKA oral anticoagulants.
Now, you were the first author of a really fantastic thing that I remember reading a couple of years ago. I think it was 2013. Can you tell us the uptake of this? Because I think it's been very popular, certainly where I've seen it.
Apparently, it was really something that people in the field like to see, that sort of information. The practical guide addresses 15 topics, clinical scenarios on how to use NOACs in clinical practice. And the key message booklet we distilled from that guide apparently has been distributed by ESC more than 350,000 times worldwide over the last 2 years.
So I guess that's an indication that people are interested
so.
and need that information. But you've been involved now in updating this, and this is going to come out next year, is that right?
Well, in fact, tomorrow.
Tomorrow?
Yeah.
Okay.
It will come out tomorrow, and it will be for free, again, for download for everybody.
Can you give us some idea about what are the changes, some of the things that have changed from 2013 to 2015?
Many things have changed because there's so much new information, of course, and we've tried to integrate it all. The full outline of the practical guide has been kept the same, so 15 scenarios, but every chapter, every table, every figure has been updated. We also have 1 new table and 5 new figures in there.
I guess, too, I think at the time that it came out, there wasn't any evidence, or at least the trials with edoxaban hadn't been reported. Have you included?
Sure, that's of course included now in full. Edoxaban was present provisionally in the original practical guide, and now we have the finalized information which is in there.
What do you think, if you could give us a few of the changes, or what are some of the important changes? If we could start with one, I think you were telling me earlier about even the definition of nonvalvular atrial fibrillation is something you've had to update.
Yeah, exactly, because that's really a source of confusion, the term nonvalvular atrial fibrillation. So we have a new chapter and a new table spelling out patients we think are eligible for NOAC therapy. And in fact, we've concluded that this is very broad, that even patients with severe aortic stenosis, with hypertrophic cardiomyopathy, that even patients after mitral valve repair or bioprosthesis may qualify for NOAC therapy. We acknowledge that all these groups do not have full information, but that there's also no reason to exclude those. The only restriction is that after surgery, the first 3 to 6 months, NOACs are not proven to be safe, so that should be excluded.
Well, that's really interesting, and I think it's helpful. So this will come out as part of the new guide, the new practical guide, not just guidelines, but practical guide, which is an important difference.
Yeah.
One of the things that I personally find very hard, and I hope this has changed, is patients who either have a stent or have an acute coronary syndrome, and I'm left with the conundrum of what to do with dual antiplatelet therapy, whether you have warfarin, and now we add the NOACs to this. Have you been able to update that, and what has changed?
We have put a lot of effort in trying to simplify this very complex matter. In fact, there were already consensus texts, for instance, from last year, ESC, HRS, AP, HRS produced consensus text, but the flow chart there was very complicated and maybe did not solve the clinical conundrum you just mentioned. So we have tried to summarize that into what we have called default scenarios. One is a step-down scenario after an elective PCI. The other one is a step-down scenario after an acute coronary syndrome.
So what do you recommend after an elective PCI?
So the default scenario after elective PCI says that you should, for 1 month, keep the patient on triple therapy and then step down to double therapy, and later on, by the latest after 1 year, go to monotherapy. The default scenario for an acute coronary syndrome is that you have 6 months of triple therapy and then go to double therapy and do monotherapy after 1 year. Now, I stress that these are default scenarios, and the flow chart we have put in the practical guide also comprises information summarizing in arrows directing in either direction which clinical factors may make you decide to even go for shorter combination therapy or in some patients for longer combination therapy. And so we really think that this flowchart can serve as a sort of a backbone for physicians in the field to start their individualized treatment decisions.
Well, for many of these, particularly the new drugs, for example, ticagrelor and prasugrel, we're really in a data-free zone as to what you do in someone who's also got atrial fibrillation. What do you recommend?
Exactly. It's a very good point. We have no information on these newer antiplatelet drugs. So this double and triple scenario step-down scheme is with aspirin and clopidogrel. And we recognize that we need more data before we can give any recommendation on ticagrelor or prasugrel.
I guess that was one of the nice things I found about the original practical guide. It just not only said what you might recommend, but it also said where the data was insufficient to really make a recommendation. So maybe this is where practical guide might drive future trials. Does stenting with a drug-eluting stent make a difference in that scenario?
Yeah, we clearly spell out that these default scenarios are based on newer generation, second generation, at least death stent or a bare metal stent for the few patients that qualify.
Now, one of the other areas where I think there is a lot of uncertainty, particularly with new therapy for acute ischemic stroke. What are the changes there, if any?
Well, we have tried to also spell out those scenarios because it's a recurring question what to do if a patient under NOAC therapy develops an ischemic stroke nevertheless. And with VKA, there was some guidance that you could use thrombolysis at least when the INR was below 1.7. Of course, with NOACs, we have no point-of-care device that can give us a rapid estimate of the coagulation status. So we stress that you have to take into account a time window of at least 24 hours after the last NOAC intake before giving thrombolysis. We hope that point-of-care test devices may become available, which would maybe simplify this, but then again, we need prospective studies to confirm such a strategy. At the conclusion of this chapter, we also recognize the recent thrombectomy trials that all have shown very positive results. Although these did not study patients on NOAC therapy in specific, we still think that this is an alternative strategy that definitely needs to be explored by physicians.
And I presume this is all going to be changed. So you'll make some recommendations about how long after a NOAC dose you might be able to give lysis, but these are hard decisions for clinicians.
Yeah, but that's exactly why we've tried to come up with this guide. All of us has to make these decisions in clinical practice, and we all make best guesses with the limited information. Maybe it's better that a group of people really delved into this, spelled out what we think at this moment could be done, and also gives the boundaries of uncertainty and where physicians in their individual decisions may divert from the default scenarios we propose. But at least it's a backbone.
And will the new reversal agents, when they're finally put into trials, will they change all this?
Well, they will change some. Honestly, there's not that much need for reversal agents. But of course, we acknowledge idarucizumab, which will probably come to the market soon. Also, the other specific reversal agents are mentioned. But there's not that much of change in the sense that if you do not have specific reversal agents available, you can still use a-specific reversal agents like PCCs. We're already in the original guide. What we learned, though, over the last 2 years is that the initial dose might need to be higher, so 50 units per kilogram rather than 25 units.
So that's an increase in dose since the last guide.
And that's an increase in dose.
Okay.
That's a change.
One of the problems that I often have is cardioversion, and either you've got a new patient who needs cardioversion, someone who's on a NOAC, or someone who hasn't been on it. What's this change, or has there been any change in the guidance since then?
We have tried to spell out these different scenarios, again, to take away a bit the confusion. Where we have good data is that a patient that has been treated for at least 3 weeks with a NOAC can safely be cardioverted, provided you're sure about adherence to the drug, of course. And if that adherence is not guaranteed, then you better do a TEE before cardioverting. Now, another scenario is, of course, the new onset atrial fibrillation, as you mentioned. And there again, we subdivide to patients that are for more than 48 hours in AF or shorter duration, we give again guidance based on the limited information that's available there.
So if it's after 48 hours, what do you do?
So we have learned from EXVERT study, the first prospective randomized study in this field, that in those patients, when you do a TEE to exclude, of course, existing thrombi, that giving at least one dose of NOAC 4 hours or longer before the cardioversion seems to be a safe strategy. Now, we recognize that this is still a limited group of patients and that we look out for confirmation in trials like ENSURE AF and EMANATE that are ongoing.
Thank you very much for bringing out the differences and the updates. I have to congratulate you and the team who work with you for trying to simplify guidelines and actually give us a practical guide, which is something we need probably for many other complex issues, not just NOACs. But thanks very much for coming to ACCEL and for telling us what we can look forward to very soon.
Thank you very much.